Hi everyone, I am Renee Marcian. I'm a graduate physical therapy student at Ithaca College, and today I'm going to be presenting my in-service on Lsvt Big for patients with Parkinson's disease. Before I get started talking about Lsvt Big and everything that protocol entails, I want to talk about some statistics that I found from the Parkinson's Foundation website that I found really compelling and just shows the true magnitude of Parkinson's disease itself. So, Parkinson's is the most common neurological disorder, with approximately 1 million Americans being diagnosed with Parkinson's disease, which is more than the combined number of people diagnosed with multiple sclerosis, muscular dystrophy, and amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. And approximately 10 million people are living with this condition worldwide. And that's a huge, huge number of people that have been diagnosed, which really just tells me research, exercises, finding a cure, whether it's medications, surgeries, new ways to rehabilitate these people, I think is becoming more and more important as more and more people end up being diagnosed with Parkinson's, struggling with Parkinson's, and whatnot. Going back to some statistics, men are 2 times more likely than women, and the onset age is typically between 60 and 70 years old. There is early onset Parkinson's disease, with an individual being diagnosed usually in their 50s, but it is not as common. And then the one that really struck me was Parkinson's disease itself costs nearly $25 billion in Social Security payments, doctor's visits, treatments, medications, etc. And I think that's a huge burden on the healthcare system and on the individual itself. Just being able to take a medication or seeing a physical therapist or an occupational therapist, whatever it may be, it costs a huge sum of money. And again, going back to the research behind Parkinson's, I think that's becoming more and more relevant because seeing Parkinson's patients will be nothing new. Being a PT student, I've worked with a Parkinson's patient. I have 2 members in my family that have been diagnosed with Parkinson's. So it is becoming more and more common that I will treat a Parkinson's patient, and many other therapists will treat Parkinson's patients. So knowing how to help them improve their quality of life, their physical functioning, mental well-being, and being able to feel independent, I think is key to really a successful relationship with that individual, and also just helping them in their everyday life. So a lot of people can look at an individual and sort of assume that they have Parkinson's disease, whether it is stooped posture, shuffling gait, tremors, whatever it may be. They can tell that that individual has Parkinson's, but not many people really know what Parkinson's is, how it affects somebody, and what's going on the inside, in the brain, in the body. So Parkinson's disease is a long-term progressive neurodegenerative disorder of the central nervous system that causes a decrease or loss in the amount of dopamine-producing, also known as dopaminergic neurons, that are found in a specific area of the midbrain called the substantia nigra. So that's quite extensive, so let's break it down. Long-term, that's meaning that when somebody is diagnosed, again, usually between the ages of 60 and 70 years old, that Parkinson's is what ends up being their cause of death. It is not like a cold that somebody gets over within a week. It's not a virus. It's nothing like that. This is long-term. This is 10, 20 years. People live with this disease until the day that they die. And that's why it's really important for rehabilitation to give them a way to just either improve their quality of life or sustain it for as long as possible. Because going to the next point, it's progressive. Usually this will start out with a small tremor, maybe a fall, weakness in the legs, whatever it is. That usually the tremor turns into large shaking. So it might start off in the hands, go to the wrist, the elbow, the shoulder, and then the person starts shaking at a more global rate. If somebody has weak legs, they might have weak arms, and then they're unable to walk. Individuals are unable to swallow, unable to talk. And that progression is usually what ends up being deadly for Parkinson's patients. The central nervous system, consisting of the brain and the spinal cord, causing a decrease or loss in the amount of dopamine-producing neurons. Dopamine is the main player in Parkinson's disease. Dopamine is a neurotransmitter. That means that this little chemical can receive signals, send it to other neurons, and pretty much that chemical, dopamine, plays a huge role in movement or motor control and reward and pleasure. So when you have a loss of a chemical that allows you to move, that shows you why these individuals have difficulty with walking, with moving, transferring, etc. And then those neurons are found in a specific area of the midbrain called the substantia nigra. So the substantia nigra is a really specific part of the midbrain, and I'm going to get into that in the next slide. But continue going down to the second bullet. The cause of Parkinson's is typically idiopathic or unknown. However, there has been research that targets genetics, environmental factors, or a combination of both as main causes of Parkinson's disease. Some links are a mutation in the LRRK2 gene, exposure to pesticides, and repeated head trauma. There's a lot of research being done. The Michael J. Fox Foundation has been pumping out research like crazy, and really there's still a lot to be found, and there's still a lot to be known about Parkinson's. But these genetic factors, environmental factors, can play a role, but usually when somebody is diagnosed, nobody really knows why or what happened inside their brain to start losing those dopamine-producing neurons. And there's no biomarker. There's no objective test that's screening for Parkinson's itself, which makes it really hard to diagnose Parkinson's, but also makes it really important to treat these individuals and give them the quality of life that they deserve. Without getting too much into the neuroscience or neuroanatomy of the brain, I want to talk about the area of the brain that is most affected by a patient with Parkinson's disease, and that is the substantia nigra. So the substantia nigra is a nucleus, isn't really a structure in the brain, and it's located in the midbrain. So right above the pons and the medulla, the midbrain is a part of the central nervous system that is associated with things like vision, hearing, sleeping, temperature, arousal, wakeness, but most relevantly to Parkinson's patients, motor control. And again, the motor control is really some of the main signs and symptoms of Parkinson's disease. So the substantia nigra looks like a dark streak in an unstained brain tissue, and it is located near the ventral tegmental area and has two regions, the substantia nigra pars compacta and the substantia nigra pars reticulata. And the pars compacta is the area that's containing dopamine. That is really the hub of dopamine neurons, and that is what shows up on cuts of the midbrain when the brain is dissected. And the substantia nigra pars compacta contains many dopaminergic tracts, meaning that these are areas that send dopamine back and forth to different areas of the brain and of the body. And it's responsible for voluntary motor and movement control, which again shows why these individuals have problems moving their arms, moving their legs, because that part of the brain that is controlling motor and movement is degenerating. Looking at the substantia nigra more specifically, we can tell by the two pictures on the left that just looking at them and maybe not knowing what they are yet, there's a major difference between the two. So looking at the right one, you can tell there's that little crease towards the bottom that is dark. It looks almost a very dark brown to a blackish. And that is the substantia nigra. And the top part of that darkish brown black area, that is the pars compacta, and the bottom, the brownish tannish color, is the pars reticulata. So if you remember, the pars compacta is where dopamine is housed, and dopamine neurons express high levels of a pigment called neuromelanin, which accounts for the dark color seen in the substantia nigra. So on the right, the individual is producing dopamine normally. But on the left, when there's a loss of dopamine, there's a loss of that neuromelanin, and then there's no dark stained pigment in the crease of the substantia nigra. It's more just that tannish brown color. But these changes can't be seen until a brain is dissected. You can't tell that somebody has lost dopamine neurons, or that the substantia nigra in their brain is not stained a dark color. But it does give us a marker of areas of the brain that are affected most by Parkinson's disease. Researchers know that dopamine, more specifically loss of dopamine, is the main cause, per se, of a lot of the signs and symptoms that start to come along with Parkinson's. But what a lot of people are puzzled on is why these dopamine neurons, the dopaminergic neurons, start to die. They become necrotic. There's some programmed cell death or apoptosis of those dopaminergic neurons. And there's a lot of proposed mechanisms for the neuronal death. One being disruption of autophagy, which is sort of how cells cycle through and they live and they die, and there's new ones being born. Changes in cell metabolism or mitochondrial function, neuroinflammation, blood-brain barrier breakdown, resulting in vascular leakiness. There's a lot of just proposed ideas of why dopamine is dying off. But the one that has continued to come up in research is protein aggregation in Lewy bodies. And Lewy bodies are abnormal accumulations of the protein alpha-synuclein, which develops in the remaining nerve cells of individuals with Parkinson's disease. So these Lewy bodies sort of clump together, and they're clumping in the nerve cells, which the nervous system and the motor system play a huge part in Parkinson's disease. They start to clump together and really disrupt and change a lot of normal brain functioning, affecting the way that the brain produces dopamine and produces other proteins and neurons and neurotransmitters that are very useful for a good functioning brain. And disrupting that functioning, it causes impairments in cognition, movement, behavior, sleep, information processing, and recognition. And movement, really the main symptom, the main impairment of an individual with Parkinson's disease, is affected by these Lewy bodies accumulating. And Lewy bodies are typically seen in Lewy body dementia, but they are also seen in Parkinson's, where researchers aren't really sure what they are and what their use is and how they come forth in the brain, but the Lewy bodies and the accumulation of them in the nerve cells of Parkinson's patients have shown in some individuals and in some research that they're decreasing the functioning of the dopamine and not allowing dopamine to be produced, and therefore dopamine dies off and there's a loss, and then the individual develops more of those signs and symptoms of Parkinson's disease. So this is a huge topic, a huge ongoing research topic that doesn't really have an exact answer now. But for right now, a lot of people think that the Lewy bodies are causing the loss of dopamine. Moving from the cause and what goes on inside the brain, we're going to move to the clinical features of Parkinson's disease. These are the features that you typically see every day with these patients. They're well known, and we talked about them earlier. These are the first things that you're going to notice about an individual that has Parkinson's disease. So there are cardinal signs. So these are really main things that if an individual has Parkinson's disease, they're likely to have many of them, whether it's one or two, whether it's all of them, whichever. And these are called Parkinsonisms, whatever it may be. These are really the main signs. These are what you're going to see first. So the first one is bradykinesia. And bradykinesia means slowness of movement. This is due to disturbances of motor initiation. So planning, initiating the movement, coordinating the movement, and executing the movement. So when an individual goes to walk, we think we're just walking, but the brain has to know where you're going. It has to start the movement. The muscles have to move. You have to coordinate it so you do not fall. And then you actually have to execute moving, walking, whatever it may be. And this bradykinesia, slowness of walking or movement, it causes many of the difficulties with activities of daily living. So going up and down stairs, getting in and out of bed, getting on and off the toilet, getting in and out of the shower. You're just slower. And performing simultaneous movements is impaired. If you have to walk in the grocery store and grab something at the same time, a lot of these patients will usually roll the cart up, stop, look, grab. It feels almost robot-like. So it's bradykinesia. The second is a rest tremor. And this is first going to appear in one hand, and it stops during voluntary movement. So if an individual is at rest, you're going to see what's called pill rolling, usually in their hands. So it's a tendency of the index finger and the thumb to touch in a circular manner. But if they're moving their hand, if they're doing something, cutting foods or reading the newspaper, there isn't a tremor. And this is usually the first sign that people will notice about an individual with Parkinson's is the rest tremor. Third, we go to rigidity. And what I mean by rigidity is stiffness, resistance to limb movement caused by an increase in muscle tone. So there's sort of a spasm, an excessive muscle contraction that makes it so the body is not very flexible. It's hard, it's stiff, and that causes a lot of problem with movement. And fourth, postural instability, gait disturbances, and balance. We can break that down a lot of ways. Postural instability, really you're going to have a stooped posture, many falls. Gait disturbances, you'll see shuffling of the feet. The patient will sometimes freeze, so it's like their brain shuts off and they forget to walk. And then impaired balance, and that's usually due to the weakness, the instability, and gait all together. And that last point, it really causes frequent falls and slipping, and that's a lot of reasons why these individuals actually end up causing broken bones. And when they fall once, the main stressor to hurting themselves is falling again. And they start to lose their confidence in being able to walk. They have reduced mobility. And when that starts to occur, the individual will start to become depressed and not want to move anymore. And then heading over to some other signs and symptoms, I've touched on shuffling of the feet, freezing during gait. And it's called a propulsive gait, and you're going to see it's really rapid shuffling. It's not picking up the feet in a normal gait pattern. You're going to see a forward flexed posture, a really humped back, quiet monotone voice. They have trouble speaking, opening their mouth wide, using those muscles. Shaky or small handwriting. Usually you can tell it sometimes looks good, and then sometimes it's hard to make out words. And finally, a masked face or emotionless. The face muscles start to become rigid, and the person has trouble smiling or showing an expression. So first, I have a little video of an individual with Parkinson's walking. You can tell the shuffling gait. She's not really picking up, flexing the knee, having good stride length, more just shuffling. She has a little bit of the forward flexed posture. And I can't really see any shakiness, but that is typically the bradykinesia, walking slowly, more rigid and stiff. That's really the prototypical way that an individual with Parkinson's might walk. Second picture here is more of a still, looking at the forward flexed posture again. And then the third video I have is the pill rolling. So that is the rest tremor, when an individual looks like they're rolling a pill over their index finger and their thumb. Individuals with Parkinson's also start to exhibit more signs and symptoms that are not necessarily motor or movement involved. And some of these are cognition, Parkinson's disease, dementia, behavior and mood changes, sleep problems, sensory disturbances, and autonomic disturbances. Starting off with cognition, Parkinson's patients will begin to have trouble controlling their attention. So they'll sort of won't be able to focus on, multiple things at once, and it will be even hard to focus on one thing at once. Their memory, especially their working memory, will start to become impaired. Difficulty planning. So really executing something and planning it out. They have slowed cognitive processing speed and impaired recall. So they're starting to have more of those mental effects of a neurodegenerative disorder. Parkinson's disease dementia. This is more of a specific dementia related to Parkinson's that is usually due to Lewy bodies that we chatted about, and the individuals will start to really forget things and be more dependent. They'll have a decreased quality of life, and the dementia really increases the probability of needing nursing home care or a 24/7 nurse or something like that, because the individual might forget where they're going. They might not know what they need, and what to do in certain circumstances. Behavior and mood changes. These are, again, easily seen on a day-to-day basis, but they're not motor related. Whether it's depression, apathy, anxiety, social phobia, panic disorders, these will really start to come about, especially the depression. The patient goes from having a relatively normal lifestyle and then progresses over time to not being able to move. And those changes are extremely difficult to take into consideration. They're hard to help with rehabilitation, and they're very difficult on the individual itself. So really being a positive light in these individuals' lives can make a world of difference. Sleeping issues. These patients will become more tired more easily, have daytime drowsiness, tiredness. They can't get deep sleep, the REM sleep that they need, and that it really starts to take a toll on the individual, and they become more and more sleepy as time goes on. Sensory disturbances. This usually isn't as common, but it can be seen in pain, numbness, tingling, down into the arms, into the legs, the low back, the neck, anywhere. And then finally, autonomic disturbances, whether it's sexual dysfunction, orthostatic hypertension, gastrointestinal issues. Again, these are really secondary symptoms of Parkinson's disease itself. We've talked about the cause of Parkinson's, the pathophysiology of Parkinson's, what you see on, a dissection of the brain. We've talked about the signs and symptoms of Parkinson's. Now we're moving on to treatments. And there's a lot wider range of treatments, but the main problem is there is not a cure for Parkinson's. So there's still ways to develop different treatment plans and ideas for patients with Parkinson's, but these are really just to improve their quality of life, hopefully improve their physical functioning or mental well-being, to allow the individual to feel safe and to feel, not feel the effects of Parkinson's, of the slowing down of the depression, whichever. So the first treatment, probably the most common treatment so far for Parkinson's disease, is medications. And usually when an individual is diagnosed with Parkinson's, usually by a neurologist, they will prescribe different types of medications. So one that's usually given is an antidepressant, just to help with the mood and the behavior. But there's one medication that is typically prescribed, and that's called levodopa. And levodopa is a natural chemical that passes into the brain and converts into dopamine. So remember, dopamine, the loss of dopamine causes many of these symptoms of Parkinson's, whether it's bradykinesia, rest tremor, rigidity, postural instability. And levodopa is substituting for dopamine or increasing dopamine to allow there to be voluntary movement. Another common treatment, well, actually not very common, it's probably the most rare is surgical procedures, which is deep brain stimulation. And this treatment is typically for people in advanced stages of Parkinson's with a decreased response to medications. This is like a last resort type of treatment. And I'm not exactly sure how the deep brain stimulation works, but it helps to reduce the Parkinson's symptoms. So it reduces involuntary movements, reduces tremors, and controls irregular responses to medications. Some other treatments are support groups, so allowing the individual to really talk about problems that they're having in every day and how others cope. Medical marijuana, depending on which state you live in and the laws and regulations about medical marijuana in that state, it has been shown to put the individual at ease and cause the Parkinson's patient to decrease some of the tremors. It's more of a blanket treatment that isn't really helping any of the problems, but it's sort of masking them and allowing the patient to feel more comfortable. Yoga and meditation are, really proven in just regular literature to be extremely helpful, not just with Parkinson's patients, but with everybody, to give them those large global movements that they typically end up decreasing. Tai Chi, massages, rock steady boxing. Rock steady boxing is huge. That's all across the country, and it's usually 2 to 4 times a week an individual will come in and pretty much go to a boxing class, and they'll work on arms and legs and stretches and fun exercises. But the main treatment that everyone should focus on, and is the cure, maybe not the cure, but a huge helper for anything, is exercise. Whether it's flexibility, so working on stretching, aerobic activities, strengthening. Exercise is a huge component of treatment for Parkinson's disease, and that will help them be able to move, be able to feel stronger, increase their balance, and really improve their physical functioning, so they don't have as many gait disturbances, they don't have as many falls, they're able to walk and do things with more confidence and be out in the community amongst people with a better state of mind. And this really leads into the main topic of this in-service, which is Lsvt, which is a huge exercise protocol and a program for individuals with Parkinson's disease. Knowing what you know now about Parkinson's and how it affects an individual and what it's caused by, we can start talking about the main topic of this in-service, which is called Lsvt Big. So Lsvt stands for Lee Silverman Voice Treatment, which was started in 1985 when Dr. Lorraine Remig, a speech-language pathologist at the University of Colorado Boulder, was asked to treat a colleague's friend who was having trouble speaking, Mrs. Lee Silverman, who had been diagnosed with Parkinson's disease. Lsvt Loud is an intensive voice and behavioral treatment that lasts for 4 weeks, and it became the first effective treatment for voice and speech disorders of people with Parkinson's disease. So you're probably wondering, this has nothing to do with Lsvt Big. Correct, but Lsvt was started by Lsvt Loud, which, like I mentioned, it's a voice treatment, and Parkinson's patients with the quiet monotone voice, trouble swallowing, trouble speaking, they really benefit from that exercise. So Lsvt Loud was later expanded into Lsvt Big when a group of physical and occupational therapists wanted to reduce the effects of the bradykinesia, the tremors, postural instability, in patients with Parkinson's and a more research-based approach to treatment. So they wanted to look at more global exercises because they noticed that Parkinson's patients, yes, they are quiet, monotone, have trouble speaking, but they're also having trouble with movement. And physical and occupational therapists want to work with movement and being able to do things independently. So going back to Lsvt Loud, they teach them thinking loud in order to speak loud, and using very exaggerated motions. So when they do the motion in everyday life, it's normal. It's normal instead of being quiet. They seem like they're talking louder, but it is normal compared to others. So it targets the vocal cords in a way of expanding the patient's capability of speaking more frequently. But going back to Lsvt Big, like I said, the patients with Parkinson's, they move slower and slower over time. And Big works on large and more explosive movements and helps the patient sort of recalibrate how they perceive their movements. And it teaches them when and how to apply the extra effort to produce larger movements. So in everyday life, myself, whoever it may be, we walk around normally at a normal gait speed. We get in and out of bed. Individuals with Parkinson's, they move slower and smaller. So they start to become more compact and squeeze in due to the rigidity. And working on Lsvt Big, it opens them up. It uses large upper and lower extremity movements, and it's very over-exaggerated. So they feel like they're moving everywhere, but they're really moving at the same speed and using the same step length or rolling as a normal individual. So it's just changing their mind to think they're doing this really big, but in essence, it's about the same, and it allows them to be extremely functional. In Lsvt, whether it's loud or big, they're protocols, and people have to be certified to teach them. But you can use the exercises in treatment, and you can also come up with your own exercises. If a Parkinson's patient came into my clinic and I didn't know what Lsvt Big was, I would start with strengthening exercises, gait training, resistance training, range of motion, functional activities, and balance training. Those are all things that I would incorporate into a treatment session, which they're all great things. But having an idea of what Lsvt Big is and how it works can only enhance a therapy session. So Lsvt Big focuses more on neuroplasticity, which is the ability of the brain to change and reorganize itself by forming new neural connections through repetitions. So neuroplasticity is allowing the nerve cells in the brain to compensate for an injury or a disease. For example, if a patient has had a stroke on one side of their brain, and that side of the brain is damaged, the other side of the brain will begin to take over numerous functions of the side that was damaged. The brain will, however, start reorganizing the damaged side and forming, new neural connections and, reconnecting the dots almost. But they need activity to be reconnected. So they can't just magically one day come back together. They need training. They need, with the PT's help, they need help moving and using their brain actively to be able to bring those neural connections back together. And that's really what Lsvt focuses on. It's so important. because Parkinson's disease causes degeneration of the brain and the death of the specific dopamine neurons. So you're losing those neural connections day by day. So to gain back those connections through exercise is key. Exercise is, firing the brain, firing the muscles, making the system work. And it's improving quality of life and the ability to be functional, as well as addressing the internal aspects of Parkinson's disease. We see the outside of somebody, whether they're moving slowly, they're hunched over. But we don't really take into effect what's going on internally, that their brain is actually degenerating. So if we can reverse almost or slow down some of those damages to the neural connections and work on a lot of repetition, big movements, the patient's brain starts to recognize that they're doing more and more and allows it to reform some of those connections to be able to continue to walk and continue to talk. And LSVT focuses on high intensity, high amplitude, and it's repetitive. You're doing multiple motions, a lot of reps, holds, and really just a lot of things throughout the day to really, really beat this LSVT into the head and make sure that the brain starts to recognize it and starts to change the body. These sessions can either be one-on-one or group therapy based. It's typically one-on-one. I haven't really seen any group therapy based online, but one-on-one allows it to really be patient specific and very beneficial to the individual. There's a lot of extra work that comes along with Lsvt Big, but it's reteaching the patient how normal movement should feel. Like I talked about in the last slide, they're used to small shuffling movements, but by using Lsvt Big, they're focusing those large, exaggerated movements. That's going to feel strange at first, but it's normal compared to other individuals. So this method, the method of the madness of neuroplasticity, is what makes Lsvt Big different from just traditional physical therapy. Just working on strength or gait is doing reps for specific muscles and specific joints. And that's awesome. But being able to change the individual's mind and their brain to help them improve their quality of life allows the individual to be able to move better and have increased confidence in every day-to-day life. The Lsvt Big program is split up into multiple categories, but the exercises are geared towards large global movements of the entire body and primarily focus on joint movement. So it's not looking at one specific muscle or one specific joint and strengthening that joint to be able to walk. It's focusing on multiple movements at once, incorporating multiple body parts and long holds that helps the individual to feel bigger and elongate their muscles and really strengthen them through exercise. And depending on the physical functioning of the patient, many of these exercises can be advanced, they can be digressed, they can be modified to whatever the patient's needs are, whether they're more comfortable in sitting, standing, or laying on their back. If the patient has a lot of trouble moving and walking, and they're more in an advanced stage of Parkinson's, then the supine position, laying on their back, will be the most comfortable, and they can still perform those exercises from that position. So it's all about knowing your patient and what works best for them. So a lot of these exercises are individual specific, with many of them actually being more patient identified. and you really get to be able to improve what the patient wants to improve and help them feel better. So I've given a little bit of history on Lsvt Big and the neuroscience and the reasoning behind it, and I'll get into that more and more later. But what does an Lsvt program actually consist of? What does the patient go through? This is 7 daily exercises that are completed each session at maximal effort. By maximal effort, I mean all the reps, all the holds, really engaging the patient in the exercises. And they're floor to ceiling, side to side, forward step, sideways step, backward step, forward rock and reach, and sideways rock and reach. And on the next slide, I'll have a video that shows and explains each one of those. But just from looking at them, you can tell that they're working on more parts of the body and working on very large motions that are used in day-to-day life. After these exercises, the patient performs big walking with exaggerated arm swings and step length. Shuffling gait, falls, balance problems are major impairments to individuals with Parkinson's. So walking and being able to walk in the grocery store, shopping mall, on grass, on gravel, on pavement, is big to allow the individual to continue to be out in the community and out with their family and friends. So it's really focusing on very large arm swings going up and over the head and working on reciprocal gait pattern. And these can be done with a wheelchair, a cane. It doesn't have to just be themselves, whatever they're most comfortable with. And then we move to 5 functional tasks that the patient performs each day. So even just sitting here thinking, what do I do every day? I have to roll in and out of bed. I have to get in and out of my car. I have to transfer from in the shower to out of the shower. I have to go up and down stairs. These are things that I do every day, and a lot of those, typically a Parkinson's patient, will do every day. But again, these are really decided on between the PT or OT and the patient. And it pinpoints those everyday things that they must complete to be independent. And when they start to when the Parkinson's patient feels as if they can't get out of bed, or they can't go upstairs, they can't open a door, they can't open a jar, they feel helpless and that they can't do mundane or easy tasks. So working on these tasks to allow them to not have to bear the burden on a caregiver is extremely important and really helps their behavior and their mood towards exercise. And then after, there's patient-identified tasks. So usually not 3 or 4, but anywhere from, say, 1 to 3 tasks that the patient finds completely important in their daily life. So these are real-world things. Whether it's putting on clothes, brushing teeth, folding laundry, throwing a ball to children, reaching for a drink, playing sports. These are typically more complex motions that have more moving parts. And these tasks are broken down and then built back up in complexity so the patient is able to perform them well and perform them without any issues. So a quick example, say an individual comes to you and they're having trouble preparing meals and cooking, and they want to do this because they want to be able to make food for themselves and for their family. So through the treatment sessions, you could work on getting ingredients. So reaching up in the high shelves, picking ingredients out of the cupboards, putting them, on a table, bringing them somewhere, getting them from the floor, whichever it may be. Gathering tools, so getting knives and forks and being able to use the dexterity in their hands to grab them. And then preparing the foods, so cutting, slicing, cooking, rubbing, whatever food they're preparing, doing that. Putting the food in the oven, so being able to hold a large pot, a large pan, cook it, stir it, and then finally being able to serve the food, so plating food, bringing it out to an individual. All of these they seem like little things and they seem easy, but to the individual, when you break them down, it really starts to be able to look at the whole picture. And then the patient feels as if they can prepare the meal. And that's all done over the course of usually 1 month. And then there's other exercises. So there's a homework and there's carryover assignments. Homework consists of guided daily exercises that take typically 15 to 30 minutes to complete, and they help the patient stay motivated and trying new exercises for the 4 weeks that they're in treatment. So Lsvt Big, I'm not sure if I had mentioned this, but Lsvt Big is a 4-week treatment session with 4 consecutive days a week of treatment that consists of all of these exercises. It usually takes about an hour to an hour and a half, depending on the patient, and it builds up with progression each week. So the homework really zeroes them in, keeps them motivated, but keeps them exercising every day. So even when they're not in treatment, they're still doing something. And then the carryover assignments are used to increase learning and memory from one treatment session to the other. And it works on those functional trainings. So if the individual was preparing the foods or putting on clothes, it allows them to do those little tasks and, increases their carryover from one session to the next.
Then you're going to count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
What? Okay, so you guys are follow along. We're just going to do a couple. Ready? Out. Down.
Up.
Out.
1,
Don't
2,
hit each other.
3, 4, 5, 6, 7, 8, 9, 10.
1. Out. Down.
Up big. 9.
Out. 1.
2, 3, 4, 5, 6, 7, 8, 9, 10.
All right.
I don't know this side, you're doing it bigger. What?
I'm winning now. I'm winning.
Hey,
Laura. Okay.
Simon. Okay.
So reach out.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Now the other direction. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
All right. One more each way.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Good.
So now she's going to stay seated. So you're going to follow along with her, but I'm going to do the standing version, okay? Yeah, alternate. 4. 1 each side. Yeah. Ready?
Next.
So follow along with her. 4, yeah. We'll count next time. We didn't rehearse too much. Okay.
So now we're going to count out loud as we do it. We're all
Next
taking
one's the
feet.
side step, okay? We can do it? Yeah. 1, 2, 3, 4, 4. Okay?
Now we're going backwards.
That step. I gotta move up. I gotta kick the curb. 1, 2, 3, 4.
Come on, Bill.
Ooh, I don't hear you guys. You're not counting very loud. Okay, next one. Yeah, rock and reach. So, this is really going to be tricky to do sit down. Don't hit it.
Just rock in your chair.
1,
Get those arms up.
2,
2,
3, 4.
5. So you guys are doing better than you. Okay, let's do 8 of them. So switch your feet. We're gonna do 8.
Okay, ready?
Make it loud.
1, 2, 3, 4, 5, 6, 7,
And
8.
good.
Alright. Ready? We're gonna start left. Yep, twist.
Oh boy.
Like that, and then up and back. She's going that way already. We're demonstrating slow so they know what we're doing. Okay, so
Do
ready?
one side, guys. One side? So. There you go.
1. You're all 3, 4, 5,
10 points if you get your neighbor.
6, 7, 8, 9, 10. Last one. Go to the other side.
Here we go.
1, 2,
Oh, this side's still winning.
3, 4, 5, 6, 7, 8,
So,
9, 10.
Like any exercise program, it takes time to get into and to build up the endurance and the tolerance to these exercises. And especially for Parkinson's patients who become tired easily and have slow gait, slow movement patterns, the rigidity, it's going to take longer to feel those effects and start to see those effects. So some challenges that the patient will face is endurance. They're not usually accustomed to exercise, and especially high intensity, high amplitude, 10 to 20 reps. That's a pretty large task for a Parkinson's patient. Not saying it can't be done, but originally they're going to feel tired. They might have delayed onset muscle soreness. They might feel weaker, but really it's just a part of the exercise process. Overall movement impairments, just their balance, whether they need to be in seated, standing, or supine. Stiffness is going to play a factor in being able to complete exercises. Pain also plays a factor, and it affects their well-being and their willingness to try and complete exercises. And their mood. Mood is going to be a really big challenge to a Parkinson's patient. They might feel, if they're doing a functional task and the task is getting broken down into multiple steps, like the example of preparing food, they might feel as if it's sort of ridiculous to break that down into collecting ingredients and preparing the food and putting it in the oven. But these patients need constant reiteration of this is helpful, this is worth it, and this helps with the big picture of actually being able to cook a meal or do whatever you want to do. And remembering and reminding these patients that exercise is amazing. It gives amazing health benefits. It helps with mood changes. It helps with cardiovascular health. It helps with a lot of things. So being able to do something is better than doing nothing at all.
Well, I came home this morning.
Say, for instance, that you are not LSVT certified, or really aren't sure how to incorporate the typical 7 daily exercises, but you still want to incorporate the idea of using large global movements. Well, developing exercises that incorporates LSVT principles makes it more fun for the patient, makes it more creative, and allows you to step outside the box. So I'm going to flash a few exercises that I came up with for upper and lower extremity that use those same principles of big motions and big holds, and that can really be seen in everyday life, going to reach for things and picking things up regardless of what it is. So with all these exercises, it's really important for the patient to know whether they're seated, standing, whatever it may be, to stand up nice and tall and have good posture with all of these exercises so they don't get into that forward flex position and they're uncomfortable. And remember, all of these can be modified to whatever is most comfortable for the patient. So with each of these, focusing on the large motions that can be easily replicated in their daily homeworks, and they're easy to progress and modify regardless. And I'd start with 10 reps each with a 10-second hold, and if they can't do 10 reps, do 5. If they can't do a 10-second hold, do a 5-second hold. So we'll bring the first one up, and that is the backstroke. So you can see, just like swimming in the pool, using those large arm motions, circling back 10 times, really giving a good hold. Second one is a wood chop, or chopping wood. So just like, you're going to chop wood, this motion is really working on the shoulder flexors, the shoulder extensors, abductors, adductors, really the entire shoulder girdle, and even incorporating trunk rotation and the obliques into this as well. Next one is climbing the ladder. So this one, just like going up and down the ladder. Now, it could be done with the leg motions, but I'm more focused on the upper extremity motions right now. So you can see the wrist is going into flexion and extension, the elbow is going into flexion and extension, and the shoulder is going into flexion and extension. So this is really good for reaching overhead, getting something in a high shelf, any of those exercises or activities of daily living that are performed overhead. Next one is the safe sign. So if you think of an umpire giving the safe sign to a runner, this is really good for chest mobility, a little bit of trunk stability, and overall arm movements. So this would help if you have to reach over something on the side of you, or holding onto the railing as you get up, whichever. Pulling a sword out. So the video that I found, the little picture is quite quick, but if you think about it, it's just taking, say you have a sword or something in your left pocket. Well, you're going to grab that, and you're going to pull it up and point it to the right of you and above your shoulder. So this one I think is really good because it actually incorporates a technique called proprioceptive neuromuscular facilitation. And that's a whole separate topic, but that really incorporates a lot of muscles and a lot of movements. So he's actually showing the D2 pattern, which again is incorporating pretty much the entire upper extremity, as well as some of the oblique and trunk rotation. And finally, the last exercise that I created was punching up, middle, and down. So the video that I have just shows the lady punching in the middle, but alternating between punching up to both sides, alternating, then punching in the middle, and then punching down. And that's going to help with the arm motions with overhead, grabbing something, and then grabbing something down low, say picking up grandchildren, getting a book off the floor, tying their shoes, etc. So all of these motions are just examples of some large global motions that work on overall range of motion and strength. And I'm sure I could make 40 slides on upper extremity exercises, but these are the 6 that I think really incorporate a lot of movements, a lot of joints, and a lot of muscles. Now moving on to the lower extremity exercises. These are a little bit harder because with the arms you can sort of do more things and feel safer because you can be seated or on your back or standing. But with lower extremity and the symptom that many Parkinson's patients have, postural instability, the lower extremity exercises are a little bit more difficult, and they might need more attention as you go through the program and you notice they have balance impairments or weak legs or freezing during gait. So these exercises will have to be modified accordingly, and they can be more patient specific. So again, I came up with some sample exercises that really incorporate lower extremity leg motions. So the first one is marching or high knees. So working on hip flexion, knee flexion, and also ankle range of motion, as well as balance. This can be done, either continuous marches or, at the top, hold that for 10 seconds and making sure somebody is nearby to give contact card assistance. Or you can do this seated, we're just picking up the hip into hip flexion. Second one is a leg kick, so like you're kicking a soccer ball, working on hip extension and hip flexion. Really good for overall motion. So in the first one, the marches would be good for stepping over something, stepping over an obstacle that's on the floor, getting in and out of the car. And leg kicks, same thing, getting in and out of the car, in and out of the shower, working on reciprocal gait pattern. These are all really useful functional activities that these exercises would help with. Third would be a side step up and pull. So exactly what this girl is doing. She goes up. She's not. Just go up, down, up, down, up, down. So you're working on upper extremity motion as well as lower extremity motion. So you could just do leg where you're sort of kicking out to the side, and that's working on really both legs. One leg's in extension, the other one is in flexion, and that's just overall good for mobility of all joints, especially the ankle and working in the trunk. Fourth is lateral leg swings. So great exercise for the hip abductors, which are key muscles in gait. These are huge muscles, and they really help to stabilize the pelvis and make it so the pelvis does not drop during gait. And the fifth one that I came up with is a modified jumping jack. So again, could be done with the upper extremity. If the patient feels as if they could jump, maybe that would be something to try. But really, overall, working on alternating, going into hip abduction, If the patient cannot balance properly, you could do tapping out to the side, which is still working on the same motion. But with all of these, especially with lower extremity, typically being more weaker than the upper, definitely providing contact guard assistance and making sure that the patient is performing these exercises as safely and effectively as possible. Coming up with a lot of different exercises might seem relatively easy, but it's when you start to incorporate the functional needs of different patients and their wants and desires. As we know, not all patients are exactly the same. A lot have different circumstances that cause different reasons as to why they can or can't do something. So I've incorporated two sort of examples or two case studies of a made-up patient that brings together different challenges in their day-to-day life and how I would structure an LSVT program around what they need. So in the first example, this is a 72-year-old male who has been recently diagnosed with Parkinson's disease and wants to start exercises. Patient has had 2 falls recently and freezing during gait while living in his 2-story home with the bedroom upstairs. Patient has difficulty with reaching overhead into high shelves, sitting on the floor to play with his grandchildren, and completing yard work like gardening and playing golf. So just, really from subjective information, we can tell that recently diagnosed, it's going to be fresh. He might have, it could go both ways. He could have, he could be very willing to try exercises and start slowing down the progression of Parkinson's, or he could be extremely upset and depressed about the recent diagnosis. But you can see from what I wrote in that he wants to start exercises and feels as if he's ready to do so. Having 2 falls recently is going to be a really big key, and that shows the postural instability, balance issues, leg weakness, and that will be a really big key to hit in the exercise program. And living in a 2-story home with the bedroom upstairs. So already identifying some tasks of what this gentleman would have to do. Navigating stairs, getting into and out of bed, rolling on the floor from on your back to sideline to sitting or to a couch or crawling if he ended up falling again. Has trouble reaching overhead into high shelves, so even looking at his home environment and how you can modify it, and that's another functional task. And then we start to go into some more patient-identified tasks that they want to be able to do. Playing with his grandchildren, gardening, and playing golf. Those are things that will make this gentleman happy, and those are things that can all be broken down and worked on. So, for the LSVT program, start with 7 daily exercises or develop your own, focusing on both upper and lower extremities. So he doesn't seem one-sided in the sense of it doesn't feel like his arms are weaker, it doesn't feel like his legs are weaker. He has trouble, with falls and freezing with gait, but also has trouble reaching into high shelves. So again, focusing on a lot of global movements of the upper and the lower extremity. So going back to the sample exercises, wood chopped would be a great one. And even coming from that high and away position to low and away with hip rotation to the same side, that would also sort of emulate a golf swing. So you can really incorporate a lot of functional needs into one. Ladder climbing would also be really good for the strength overhead. And really any of the 7 daily exercises we saw from the video earlier, those would all be perfect to incorporate and would be good for overall movement. Next, heading into the big walking, just from the subjective, freezing during gait. It's going to be really important to start a walking program and allow the patient to feel safe in his own home and in the community. If he's doing yard work like gardening, he's going to be on uneven surfaces and grass, so walking is just that more important. Over time, this can progress to stepping over cones, or an obstacle course, balancing on a foam pad, because he's going to have to know how to sort of navigate those type of community places. Then going into the functional tasks, sit to stands from the chair, transferring from chair to floor or floor to couch, putting plates or food into shelves, going up and down stairs, getting in and out of his car. Those are all things that, from the subjective information, you can tell he needs to do every day and would help him improve his quality of life. And then we go into some more patient-identified tasks. Golfing and yard work were his two main things. This is what he wants to be able to do. So for golfing, you can think about walking with a golf bag or putting the bag into the cart, taking clubs in and out of the golf bag, the hip rotation during swinging, swinging and driving a golf club for long distances, putting, which is more fine motor skills. The sport of golf can really be broken down into multiple components, and the big walking is also going to help back and forth. And then yard work, we can also break down yard work a lot. So putting water into a bowl and carrying it to the flowers or plants, just being able to turn on the faucet, having the strength in the hands to hold the bowl, bending down and watering plants. Digging up dirt and planting seeds are going to be really important. So working on that, sit to stands and sort of floor maneuvers where he's more on his knees and crawling to certain areas and having to get up and get more seeds or move dirt around. Pulling out weeds is also something. A lot of people have weeds in the garden, and for a pretty garden, you don't want any of those. So being able to pull out weeds and get back onto his knees in a crouching position are going to be really important. So, there's a lot of things that you could do with this type of patient. But again, in hoping to improve their quality of life and their safety and their independence is really what matters the most. So it all comes down to a clinical judgment of what you feel is going to be most beneficial towards the patient. But it's also understanding the patient and letting them decide what kind of care and what kind of exercises they believe is best for them. The second example I have is a 57-year-old female who was diagnosed with Parkinson's 3 years ago. The patient has become upset that she needs help cutting foods, pouring her own drinks, and handwriting due to her hands feeling weak and shaky. Patient has trouble putting on clothes and walking out to her car due to a gravel driveway. Patient says opening up the door to the car is difficult and notes difficulty with handling money to cashiers or swiping, inserting her credit card. So from the looks of this case, she's been dealing with Parkinson's for 3 years. It's been progressing. There's things that she loves to do and is having difficulty doing, and she's becoming upset and possibly depressed. So these are things, those behavior changes are going to be really key to look for, but also to help keep the patient motivated and understanding the big picture of, we know this is progressive, we know this is neurodegenerative, there is no cure, and that's understandable, but we can help you now to ease the burden now. And for this type of patient, you can tell that it's more upper extremity related. Cutting foods, fine motor skills, pouring her own drinks. That takes strength in the hand musculature to be able to, hold a milk gallon or orange juice or anything like that and be able to pour it into the glass. Handwriting is one of the signs and symptoms of Parkinson's disease that becomes weak and shaky. So again, looking at that fine motor movement of her fingers. Has trouble putting on pants, or clothes, And that is typically a lot of upper extremity work, being able to pull up pants, put on a bra, put on a shirt. The only thing that you notice that might show a little bit of lower extremity weakness is walking out to her car due to a gravel driveway. So we're not sure. She didn't mention any falls, but it could just be because it's an uneven surface and she's uncomfortable with that. But it's still something to monitor and continue to work on with the Big walking program. Opening the car door is difficult. Again, that takes hand strength. And then handling money to cashiers or inserting her credit cards. Dexterity of her fingers and use of her hands seems to be on an initial that is relatively weak. And that will be something to work on later in the identified and functional tasks. So if we start looking at the LSVT program, of course, the 7 daily exercises. And I wrote, incorporate hand motions into these movements. So instead of doing a floor to ceiling and, whichever, anything like that, really focus on, the hand, maybe looking at doing wrist flexion and wrist extension during it, finger flexion, finger extension, make a fist, count on your fingers, touch the tips of your fingers during each of those motions, which would make it more specific to the patient, and also being able to work more joints that are relative to her. So again, just really picking 7 daily exercises that you come up with or that are already in the LSVT protocol. Next, looking at Big walking. So I wrote focus on uneven surfaces by using a foam pad or a Bosu ball. Again, this would be something as a physical therapist you'd have to monitor. Are they having falls? Do they report any weakness in their legs? What is the tone of their lower extremity musculature like? Is it very rigid? Is it hard? Or is it a normal muscle tone? So with this individual, you could probably be a little bit more advanced by using a foam pad or a Bosu ball. But with everything, ensuring safety, definitely having contact guard assistance for this individual, because if they started to lose their balance and had to grab onto something, they probably wouldn't be able to due to the decrease of strength in their hands. So I think Big walking is important in general, but you can really advance with this a little bit more due to uneven surfaces. Heading into functional tasks, carrying 1 gallon jugs of water or milk, orange juice, any kind of carton of liquid, really. Opening and closing a car door or just doors in general, working on that supination and pronation of the forearm and pulling the car door, pulling it shut. Transferring into and out of the car. So she never really mentioned anything about having difficulty with that, but you're going to assume that if she's opening the car door, she has to get in the car. So I think that will be really something that will translate into everyday life with, getting on and off the toilet, into and out of the shower. Putting on clothes is something she's going to have to do every day. And that can really be broken down, or that can be done as a more global functional task. And then handwriting. Handwriting is going to be important for, writing letters or bills or anything like that. And then the last, patient identified tasks. Cutting foods and handling money and credit cards, I think, are really big things that the patient is going to want to do. Cutting foods. You could wash the dishes, preparing to cut the foods by bringing out knives and forks and, using her hand to open drawers. Cutting easier vegetables like cucumbers or zucchinis, and then progressing to harder foods to cut, like tomatoes or peeling a potato or shucking corn. You can really progress that in multiple different ways, and depending on what kind of meals the patient likes and enjoys making. Putting the foods together to make a meal, putting the food in the oven and eating it, and using her hand to grab a spoon and whatnot. So just the art of cutting a food or preparing a meal can be broken down a lot. And then handling money and credit cards. This might be a little bit more difficult because it seems like a mundane task, but again, this can be broken down as well. Picking up cash and coins from the table and stacking them together. Being able to flip through dollar bills. So again, the fine motor movements. Getting money from a wallet or a purse and giving that to a person. Slipping out a credit card and swiping it by flexing the wrist. So continuous wrist flexion, or even like inserting a chip into a credit card reader. And dealing money, sort of like you're playing Monopoly. So quick flipping through the cash, being able to give it to multiple people at once, counting money quickly. All those things can be really broken down and progressed over time. It's a little bit more difficult of a case, but it can still have enormous effects for the individual. So with all of these, and with the 72-year-old male above, remember, you're going to have all these, and you're going to want to see from the patient how they feel about them, if they feel as if they're improving, and also if there's anything else that arises that you feel should be addressed and worked on. So what is the use of a physical therapist in Lsvt Big? Why are we needed to help the patient? There's really a plethora of reasons why a physical therapist, a speech language pathologist, and occupational therapist are helpful in the Lsvt protocol and the rehabilitation of Parkinson's patients. First and foremost is to, before anything, ensure the patient is as safe as possible. You don't want them to fall or hurt themselves during these exercises. And you want to teach them safety and effectiveness. So if they are living home alone, they can perform these safely, and they can perform the identified tasks with more independence. And being able to show the patient the correct way to do them without compensation. If you want good leg motion, you want to teach them good leg motion without really bending the trunk or flexing too much. Whatever is most comfortable for the patient, and giving them a lot of instructions so they know what to do and they can perform the carryover assignments and daily assignments with ease. And physical therapists, this third bullet, being empathetic and motivating. Parkinson's patients, they're going to go through mood swings. They're going to have their good and bad days. But being able to be, the person to talk to, the shoulder to lean on, and being there for them, but motivating to get them to get in and out of bed and come to treatment will be so much more beneficial in the long run, and really help you build that patient-client relationship that is so key in physical therapy. Being a person that they can trust, being knowledgeable if they have questions, if they have any problems with the exercises, just being able to modify it so they know that you're not hurting them or pushing them too far. And that leads right into the next bullet point, is watching for changes in mood. If they feel as if something is too difficult, or they feel like they're not improving, or some of these tasks seem so simple and why can't I do it? Making sure that they know that you're looking at the big picture and helping them see how it's going to help step by step. Sort of looking at the long run circumstances of doing Lsvt Big. being able to progress the patient effectively and efficiently without overworking the patient. Parkinson's patients are known to tire easily, and they're going to become drowsy and fatigued. So not throwing 30 repetitions at them when they only started 3 days ago. So knowing the proper way to progress and when to progress. And again, one of those, sort of above all things, it's one-on-one time with the patient to really listen to their wants and their needs. And, sort of bringing in that group therapy feeling that they're wanted and they're important to you. So really, this is another one of those slides. I can make 12 of these, but it really boils down to being safe, teaching effectively, and overall being a person that the patient can look to as truly somebody that cares about their well-being. Research is really key in Parkinson's disease, and Lsvt Big has been a staple in some of the research that is being done for treatments that help patients with Parkinson's. So, does Lsvt Big actually work? Does this actually help improve everything that we want it to improve? Gait and slowness of movement, just being able to function independently. So I'm going to dive into some research. Now, there's a lot of research currently being done, and there's a few really good studies out, but there's still a lot more research to be done and to dig a lot deeper into LSVT itself. So the first study I looked at is a 2018 study titled Lee Silverman Voice Treatment, Lsvt Big, to improve motor function in people with Parkinson's disease, a systematic review and meta-analysis. So this wasn't a specific study actually testing individuals, but they took other studies and collected all the data and looked at trends and different things that they were seeing, and they noticed that over 4 studies that there was a significant improvement in motor function assessed with the Unified Parkinson's Disease Rating Scale, which is pretty much just an outcome measure that shows improvement or digression in patients' independence and physical functioning. There was a trend noted of a faster tug. So the tug is the timed up and go test. Usually we see this mostly with Medicare patients, but it's a good outcome measure to show their gait speed, risk of falling, etc. And these patients that went through Lsvt Big had a faster 10-meter walk test. So this is showing that these individuals are able to walk longer with an increased speed, which is a fantastic outcome. And finally, Lsvt Big was proven effective at increasing motor function compared to general exercise. So, Lsvt Big by itself is fantastic, and it's still a really good protocol. But against other exercise programs, how does it compare? How does it stand up to those? And from looking at 4 different studies, these researchers noticed that general exercises, like your typical strengthening and gait training and balance and whatnot, Lsvt Big, with all the research that's put into that and being more specified, was more effective than general exercise. A second study is a 2014 study titled The Application of Lsvt Big Intervention to Address Gait, Balance, Bed Mobility, and Dexterity in People with Parkinson's Disease, a case series. So they looked at 3 different patients that completed the Lsvt Big program of the typical 16 sessions in 4 weeks, as well as a home exercise program. So all of those impairments, gait, balance, bed mobility, and dexterity, are Some of the common symptoms of Parkinson's disease that can cause the most issues. So they wanted to know, these researchers wanted to figure out, does LSVT actually help with those main signs and symptoms? So there was a lot of outcome measures that were tested pre and post, and some that I sort of pulled out. There was a lot more, but I think these are most relevant in regards to what we've been talking about in this in-service. Functional gait assessment, or the FGA, functional reach test, or the FRT, timed up and go, the TUG, which is what we just talked about in the last slide, freezing of gait questionnaire, FOGQ, and the motor score on the Unified Parkinson's Disease Rating Scale, the UPDRS. So those were all outcome measures that were assessed pre and post. So they had 3 patients that qualified for this study. So 3 patients really isn't a good sample size to look at, but it still gives you a clue of improvements in individuals. So before LSVT, all 3 patients showed balance impairments, an increased risk for falling, signs of freezing during gait, difficulties getting in and out of bed, and hand dexterity, moderate gait abnormalities, and bradykinesia. So these are your quote-unquote prototypical Parkinson's patients that are showing the cardinal signs of the neurodegenerative disorder. These patients were instructed with LSVT, a home exercise program, by a certified clinician. And after LSVT, all patients increased their scores for the FGA and the FRT. For the FGA, scores increased for all patients, but however, not more than the minimal detectable change, which is pretty much a number that signifies, if you get over this amount, then that is true change, measurable change. But they improved, but not enough to say this was statistically significant. And for the FRT, the functional reach test, 2 out of the 3 patients had higher scores that exceeded the MDC, the minimal detectable change. So they all increased their scores, but with the functional reach, the 2 patients actually had a true change in their physical functioning. Moving down the line, patient 2 experienced less freezing of gait and improved on the FOGQ score. Patients 1 and 3 performed bed mobility tasks, so sitting to lying down, turning over to the right and the left in bed, and sitting up from the supine position quicker. So they were able to not only complete the task, but do it in a shorter amount of time. All patients had improvements in dexterity of their non-dominant hand. However, no significant changes were noted in their dominant hand. So they could have had an increase here or there, but nothing to say that their strength and dexterity changed in the hand that they use for feeding or handwriting. And all patients had improvements in personal goals in regards to functional tasks. So some patients wanted to be able to go up and down stairs quicker. Some patients wanted to be able to pass their driver's test and be able to look to the left and right and turn the wheel. And the patients after Lsvt Big noticed, they noticed a change in their physical and mental well-being, and they were able to do tasks that they enjoy doing and that they have to do each day. The 2 other studies we looked at were more single task based, getting out of bed, just gait assessment. The last study that I found sort of drew my attention, and this one is titled the JFK Big Study, the impact of Lsvt Big on dual task walking and mobility in persons with Parkinson's disease. So breaking that down, dual task is doing 2 things simultaneously, whether it's reaching and walking or grabbing something and sitting down. It's being able to do 2 things at once, whether it's thinking about something while you're walking, talking while you're walking, whatever it may be. The researchers identified that improvements are typically noted in singular tasks post-LSVT treatment. And you saw that in the 2 other studies that the patients had increased physical functioning, whether it's with walking or strength or balance. But these patients, Parkinson's patients, continue to struggle with completing 2 tasks at once. And, majority of our everyday life is spent doing 2 things at once. It takes a lot more time to, do one task than do the other, or focus on one task and then perform the other. And that ends up being a real trick and a real impairment for Parkinson's patients, because cognitively they can do it, but they have to think about it longer. The processing information takes more time. And, the part of the brain that is affected by Parkinson's, the midbrain, the substantia nigra, that is the area of the brain that controls planning, coordinating, executing movements. So when that brain starts to degenerate, there's impairments with actually going through an entire task. And there's also problems with motor control. So doing those 2 things at once, usually these patients have to compartmentalize and pick one thing to do and then the other. So, researchers believe that Parkinson's patients focus majority of their attentions to a cognitive task, or remembering what to do while they're moving, thus causing a decrease in attention to their motor task and increasing their chances of falling. I've seen this firsthand with my aunt. She, she'll be walking down the hallway and, she'll be holding her laundry basket and she thinks of something and then ends up falling. So the cognitive part and thinking through the process of doing something causes an increased chance of fall. And that can be very detrimental to an individual and cause possibly more impairments and a decreased level of confidence. So these researchers performed a study looking at pre and post measurements taken for the TUG motor and TUG cognitive for all 114 patients that were in their study. So TUG was an outcome measure that was used in the other 2 studies that I mentioned. So that's performing a sit to stand, walking 3 meters, turning around, walking back to the chair, and sitting down, and recording the speed, recording the time and then calculating the speed of gait. And this is correlating to a fall risk. The TUG motor is the exact same timed up and go test, but with carrying a glass of water. So this is looking at your functional mobility. Just like I mentioned with my aunt, walking and carrying a laundry basket, being able to talk on the phone and sit up and down. Doing that, cognitive or a motor task as well as doing something else that requires physical motor functioning. And the timed up and go cognitive test, which is, again, performing a timed up and go and reciting the days of the week in a backwards order. So really having to process information and think about something while doing a motor task. So they did pre and post measurements for all of those, and I put a little screenshot of the information that they gathered, and you can see that post Lsvt Big treatment, so they went through the 16 sessions through the 4 weeks, all of the baseline measurements actually decreased. They were able to perform the TUG quicker, TUG cognitive quicker, and TUG motor quicker, each with having statistically significant differences. So this study is showing that yes, Lsvt Big does help with singular tasks, but it also has the potential to improve the ability of Parkinson's patients to do dual tasks, which is what we do in everyday life. And again, more research is really needed to see the long-term effect of Lsvt Big, but we have a really good sample of a lot of good researchers and their studies that show Lsvt Big does improve some of the symptoms of Parkinson's and allows these patients to walk quicker and do the tasks that they do normally. So I linked a few patient videos that I found on YouTube. So the first is before and after progress videos. These are really amazing and miraculous that on the first day someone will come in and it'll take them a long time to put on a jacket, over a minute. And then over the course of 4 weeks, they only take 10 seconds to put on their jacket. So these videos show real progress and real reason why Lsvt Big is so important in the treatment for Parkinson's patients. The second sort of topic is news articles on Lsvt Big, giving live patient commentaries on how they feel their lives have changed since Lsvt Big, and really the effects it has on them and their mood. And then third topic is another patient perspective. So again, that's looking at what the patients have to say about Lsvt Big, any struggles, any hardships, and victories with it. So those are all linked. I won't put any into the video, but pretty much if you go on YouTube and type in Lsvt Big, there's multiple videos that come up of people discussing Lsvt Big and how beneficial it was to them. What are the goals of Lsvt Big? What do we want to get out of this exercise protocol? We don't just do this protocol for fun. We don't do large global movements and large exercises just to watch the patient do them. We really want to improve Parkinson's patients' quality of life. That's so important for them, and being able to feel like they can do things regularly without help. So improving quality of life is probably the overarching goal of Lsvt Big. But we really want to get patients to use larger movements automatically in everyday life and slow down the process of certain signs and symptoms of Parkinson's, like bradykinesia, gait and balance disturbances. They're going to continue to progress, and that's known, and that's very difficult to stop. But if we can slow it down and allow the patient to live out the best years of their lives, then that means, our job is done and Lsvt did what it was supposed to do. Another really big goal is long-term carryover and maintaining those large movements. So when Lsvt, the program is done in 4 weeks, that doesn't mean that the patients should stop. They should continue to use those large motions and use daily exercises and activities to continue to slow down the process of digression. Another goal is increased confidence and safety in multiple different environments. A patient will feel more confident, hopefully feel more confident to be able to go out with their friends, play with their grandchildren. If they fall, then being able to get to a couch and roll onto a couch and call 911. Being able to go to the grocery store by themselves. Just being able to do things safely and effectively in the community without feeling like they're going to hurt themselves. Reduce dependence on caregivers and family members. Usually with Parkinson's patients, over time, they either have to go into a nursing home or have a home health agency come in 24/7. And for somebody that has been living 60, 70 years, they feel helpless and they feel dependent on somebody when they don't want to be. So using Lsvt Big and working on the functional tasks and the patient-identified tasks that allows them to truly work on things that they feel are most useful to them and help them regain their independence. And again, like I said, improved independence and improved quality of life are always big goals with any Lsvt Big patient. With any patient in general, we want to improve their independence and quality of life, but especially for Parkinson's patients who will exhibit signs of depression and anxiety because they can't do things that normal people are doing. So we want to make them happy and healthy so they can really live out their best years. Finding a physical therapist or an occupational therapist is relatively easy. You can go on Google and type in PT, OT in my area, and you'll get probably 10 to 30 hits of people. But Lsvt certified clinicians are definitely more rare, and these are usually OTs and PTs and speech-language pathologists. So I included a slide that shows how to find a certified clinician near you. So first go to lsvtglobal.com, which is the main website for the Lsvt Loud and Big. And that site in general, besides finding a clinician, it will give a lot of information about Lsvt, the process of it, the research behind it, the meaning behind it, the science behind it, and whatnot. So if you're ever curious, Lsvt Global is a great website to find a lot of information on. So once you head to that website, in the upper right-hand corner, click on a red box that says Find Lsvt Clinicians. So I have a little screenshot of what it looks like once you get to that page. So it's going to be that top red box. So you're going to click on that, and you come to a screen that's going to give you 3 options to choose from based on your needs. So whether you want to do Lsvt Loud with SLPs, Lsvt Big with an OT or PT, or if you want to do the Lsvt Loud online. Whichever you want, you just click on the box, and then you're going to type in your location, so wherever you are in the world, wherever you might be, you're going to put in the city or state or your postal code, and it gives a little sliding scale of a radius. So if you live in the country a little bit more, you can put your radius to 30 miles, 50 miles, so it gives you more of a chance to see really who's around you that's Lsvt certified. And then you press search. So once you press search, you'll scroll down to the bottom, and there's a whole list of clinicians in your area that are Lsvt certified and willing to accept patients. So I tried this out with Ithaca, and I got a few hits, and then I also tried it out with Dixon City, and I got a few hits as well. So Lsvt certified clinicians are not a rare species. They're actually becoming more and more common. So being able to find one is probably not that difficult, but even if you went to a physical therapist, again, it's becoming more common that PTs or OTs know to use large global movements with Parkinson's patients. So they'll usually be able to incorporate a lot of those into the treatment session. I've talked a lot about what Parkinson's is and how it affects an individual. And then I talked a lot about Lsvt Big and what that is and what that entails and how that helps an individual and the research behind it. So I want to give a few final thoughts on Lsvt Big and what I think about it. And I truly think after researching it and seeing videos and patient testimonials and research on this, that I think it's a fantastic program that has true results for an individual with Parkinson's disease. I think that it makes them exercise, which is extremely beneficial, but it's extremely patient specific. So it's really a collaboration between the patient and the physical therapist, the OT, the SLPs. It's more of a team effort. It's not the Parkinson's patient having to go through all of this by themselves. So I think encouragement is key. Being able to motivate somebody extrinsically, intrinsically, and letting them know that, if you do this, this will help with X, Y, and Z. And I think getting across to them that they will be able to do things that they love, and it might take some time, and it might be a pain, but they will end up getting better. And, making sure the patient knows that Lsvt Big is not the cure for Parkinson's disease. There is no cure yet, but it will help slow down the process of some of the signs and symptoms of Parkinson's disease, like bradykinesia, like gait abnormalities, like balance problems. And if they can slow down those things, they can live a happier and a healthier life. Being creative, I think, is something that Lsvt Big allows therapists to do. It gives them the freedom to really understand a patient and what makes them tick and help them develop ways to combat with different signs and symptoms. So really, the more fun that you and the patient have coming up with exercises, the more willing and motivated they are to do them. And it makes it so you are not telling them exactly what to do, but it's a team effort and the individual feels involved in their rehabilitation process. And finally, I think above all, Lsvt Big gives you truly an amazing opportunity to build a lasting relationship with the patient. They understand how hard you've worked to come up with exercises and see them through an entire treatment program. And when they feel better, they trust you more and they'll go back to you more, and they know that you are there to help them with whatever they need. So, this little picture on the right, believing in yourself. If you see yourself as a huge person with a great enthusiasm and large arm swings and step length and, whatever it may be, you have a lot of confidence and you feel just on top of the world, when really you might just be, a normal individual. That just shows, really the mental health of it and being happier and healthier. That will continue to motivate the patient to get out of bed in the morning and do things that make them happy. And I think, those are the unforgotten things with Parkinson's disease. So I think being able to really help the person feel confident and independent really means the world to these individuals. So I hope that whoever's listening enjoyed this in-service on Lsvt Big. I'm sure through the coming years there's still going to be a lot of research done on Lsvt Big and maybe more exercise protocols on ways that will help Parkinson's patients. And who knows, there could be a cure that is in the works for Parkinson's. But nonetheless, I hope you enjoyed listening to this, and I hope you learned something. And whether you're working with an individual with Parkinson's or know somebody, this will give you a background on what to do. So thank you for listening, and I hope you enjoyed.